Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Well, hello, everybody. Welcome to the webinar on precision imaging in liver MRI. My name is Victoria Chernak. I am a professor of radiology at Columbia University Irving Medical Center, and it is my absolute pleasure to talk to you today about hepatobiliary imaging. So what is hepatobiliary specific contrast agent? It is a type of contrast agent which allows us to obtain hepatobiliary phase where the contrast is uptaken by the background parenchyma, and as a result, we increase the contrast between the normal liver and the background parenchyma. Currently, there are three liver-specific MR contrast agents that are available, of which two, gadazatic acid and gabapentin, are available in United States. And for the purposes of this discussion, we're going to focus on gadazatic acid because generally this is the one that's used most commonly because as you can see, about 50% of it gets excreted into biliary tree, and hepatobiliary phase is obtained at 20 minutes, which makes it much more technically useful. This is how we're going to talk about. We're going to start a little bit of background, talk about applications, discuss some pitfalls, and then touch upon some protocol tips and tricks. So when we think about gadaxidate versus all other extracellular contrast agents, we have to understand the differences between the phases of enhancement. This is the same patient imaged with extracellular contrast agent and gadaxidate, and you can see that the arterial phase images look identical. If I remove the labels, you wouldn't be able to tell them apart. I can say the same thing about portal venous phase. You can see that the appearance is pretty much identical. However, once we get up to about 3 minutes post-contrast injection, you can see that the appearance begin to be different because with gadaxetate, because it is a hepatobiliary agent, the background parenchyma begins to uptake contrast more and more, and the contrast between the background parenchyma and the intrahepatic vasculature begins to change, making the appearance very different from what we're used to with extracellular contrast agents. And about 15 to 20 minutes following contrast injection, you can see that the appearance is quite different. There's a much higher enhancement of the background parenchyma so that the vessels appear hypointense as opposed to what we usually used to having hyper enhancing vasculature with respect to the background parenchyma. So again, arterial portal venous phase appearance are going to be very, very similar, and the stark differences are going to be starting around 3 minutes after contrast injection. How do we use gadaxetate in a healthy liver? Well, the largest and the original use for this contrast agent was to differentiate between focal nodular hyperplasia and adenoma. Consider these two patients. They both have these two lesions. Both of them have arterial phase hyperenhancement, and then both lesions fade, meaning they become imperceptible on portal venous and delayed phases. So just based on the images I'm showing you, it's very difficult, if not impossible, to tell which one is which. However, if we image these two exact lesions now with gadaxetate, you can see that now we can tell them apart. Again, on arterial and portal venous phase, the lesions look very similar like they did before. However, you can see that the lesion on top is hypoenhancing or hepatobiliary phase, where the lesion on the bottom retains contrast. And it turns out this is the key to differentiation between adenomas and FNHs, where low hepatobiliary phase hyperintensity signal has about 95% specificity for adenoma, and having iso to hyperintense signal hepatobiliary phase is highly specific for FNH. And this is meta-analysis that showed that presence of low hepatobiliary phase hyperintensity has about 95% pooled specificity for distinguishing between FNH and adenoma. Another way we use gadaxetate in patients who don't have parenchymal liver disease is detection of metastases. Consider these two patients. Both of them had history of neuroendocrine primary tumors, which means that we expect hypervascular pattern of metastatic disease to the liver. And notice that we have these two lesions. Both of them are hyper enhancing on arterial phase and kind of become iso to slightly hypo enhancing on portal venous phase. So are these hypervascular neuroendocrine tumor metastases. And when we look at diffusion and hepatobiliary phase, notice that the lesion on our left actually is hypoenhancing on hepatobiliary phase, confirming that this is a true metastasis as opposed to the lesion on our right. You can see it's isoenhancing, so that is FNH, and now we can distinguish these entities. How about this case? This is a patient with newly diagnosed colon cancer, had a staging CT, and on the CT, we noticed this very subtle hypodense area. We weren't sure if it's real, if it's real, if it's metastasis or something benign. Patient underwent MRI with gadaxetate and noticed that there is clearly hypoenhancement on hepatobiliary phase, confirming that this is a true space occupying lesion. It had diffusion restriction. It was not very bright on T2, so we confirmed that this is a small metastasis. When we reviewed hepatobiliary phase, we also noticed that, wait a second, we have this additional area of decreased signal intensity, confirming that there's an additional lesion in this liver. When we go back, we notice that there's restricted diffusion. It's kind of intermediate, vaguely hyperintense on T2, not a cyst. So now we were able to detect an additional metastasis in a different segment of the liver. And actually, when we go back to CT, we can actually, in retrospect, vaguely see this lesion. It was not noted prospectively. So now we have two metastases, and these metastases are in different segments. So you can see that this really may affect patient management, especially if patient was planning to get surgical resection of these metastases. And if we look at comparative diagnostic accuracy of CT versus gadaxetate MRI, you can see that overall sensitivity and specificity of gadaxetate MRI tends to be higher compared to CT. And if we look at all size metastases, about 30% higher odds, higher sensitivity. And for tiny mets, less than 10 millimeter, sensitivity is more than doubled. And these discrepancies actually change management in about 17% of the patients, just like the case I showed you, where presence of additional metastasis really would change surgical approach. So what about use of gadaxetate in patients who have chronic liver disease or cirrhosis? And there's a large use case for use of gadaxetate for detection and diagnosis of HCC. As a background, if we think about how HCC appears with extracellular contrast agents, right? If we look at our arterial, portal venous, and delayed phase, this is the curve that we expect for our background liver parenchyma, where the peak enhancement happens at about portal venous phase and kind of trickles down after that. And then the HCC peaks in arterial phase and then really dips down on a portal venous and delayed phase. And this is what we see on imaging, right? This curve manifests as avid arterial phase hyperenhancement on arterial phase, and then lesion appearing hypoenhancing to the liver parenchyma on portal venous and delayed phase, which is our washout appearance. When we look at the appearance of HCC with the use of gadaxetate, about 80% do the following. Remember, the liver will have a little bit different curve where it will continuously uptake gadaxetate over time until it peaks at the timing of hepatobiliary phase. However, for about 80% of HCCs, the enhancement curve of that lesion will be unaltered by the use of gadaxetate. And this is the same case that I showed you before, but with Gedaxidate, you can see we see nice arterial phase hyperenhancement, we have washout, and now you can see that the contrast between the background parenchyma and the lesion is becoming really, really, really prominent by the time we get to transitional hepatobiliary phase. However, in about 20% of the cases of HSCs, something else happens where the liver uptakes getaxetate, but also some uptake happens in the HCC itself, where it can end up enhancing iso to hyper with respect to background parenchyma. And this is example of such a lesion. Again, on arterial portal venous phase, the appearance will be preserved, arterial phase hyperenhancement and washout. And then by the time we get to hepatobiliary phase, you can see some areas of increased enhancement. It turns out this hepatobiliary phase hypointensity is super important because majority of dysplastic nodules are going to have it when we look at early HCCs, which is exactly when we want to pick up our HCCs. Majority of them are hypoenhancing on hepatobiliary phase. And if we look at hepatobiliary phase as a feature, it is an independent predictor of early HCC, even after we account for arterial phase hyperenhancement, diffusion restriction, and lesion size. So it's a very important feature. If we look at hypovascular nodules, which are noted on CT, and then try to figure out which one of them or how many of them will end up developing arterial phase hyperenhancement, meaning they will turn into classic quote unquote HCCs, we can actually subgroup the patients based on hepatobiliary phase appearance. So these hypovascular nodules on CT, if they also have hepatobiliary phase hypointensity, within 3 years, 41% will turn into classic HCCs, as opposed to only 7% of ISO enhancing on hepatobiliary phase nodules, as opposed to zero, none of those which are hyper enhancing on hepatobiliary phase. I want to really highlight, however, that hepatobiliary phase hyperintensity is not specific for HCC because multiple other things can give you hepatobiliary phase hyperintensity. As you can see here, benign, other malignant lesions, non lesions, they can all produce hepatobiliary phase hypointensity. So we should not look at it in isolation. We look at other sequences. And you have to keep in mind that hepatobiliary phase hypointensity is specific for an area which lacks functional hepatocytes. Okay, back to hepatobiliary phase hypointensity. If we look at the hepatocarcinogenesis, we start with regenerative nodule and over time get to progressed HCC. Notice that the near arterialization, that hallmark of arterial phase hyperintensity, really starts to develop at the level of small progressed HCC. However, the loss or decline of OATP expression, which is the molecule that handles geraxetate uptake, that begins to decline way earlier at the timing of dysplastic nodule. So between these two events, we have the collection of these nodules, which we term as hepatobiliary phase hypointense nodules without arterial phase hyperenhancement. And you can see that both dysplastic nodules and early HCCs fall into this category. So what are these hepatobiliary phase hypointense nodules without arterial phase hyperenhancement? If we look at patients who developed new classic hypervascular HCC and go back, anywhere between third to 44% have these hepatobiliary phase hypointense nodules without AFI. If we go back the other way, when we start out with these nodules, up to 40% eventually turn into hypervascular HCCs, as opposed to nodules which are hyper intense on hepatobiliary phase, only up to 4% will end up becoming hypervascular HCCs. If we look at cumulative incidence of hypervascularization, by 5 years, 50% of these hepatobiliary phase hyperintense nodules without AFI will turn into classic HCC, as opposed to only up to 2% of nodules which are hyperintense on hepatobiliary phase. Just an example of what we will see are these right? So we see this subcentimeter nodule. It does not have arterial phase hyperenhancement. It is clearly seen as a hypo-enhancing focus on 20-minute hepatobiliary phase. And in this case, 8 months later, you can see the lesion is larger. It has clear arterial phase hyperenhancement. It has washout. It has hepatobiliary phase hyperintensity. And this is LIRADS 5, definite HCC, can be diagnosed without biopsy. So use of getaxetate in patients with cirrhosis has some advantages. We do have improved sensitivity for HCC. A large meta-analysis, almost 16,000 patients, showed that compared to all other modalities, getaxetate has the highest overall per lesion sensitivity and positive predictive value, and that is particularly important for lesions which are less than 20 millimeter in diameter. So the reason why this is so, gadoxetate does improve lesion conspicuity. You can see this is the same case, arterial phase and portal venous phase with extracellular contrast agent. We can see this lesion, but you can see the contrast between the lesion and the background parenchyma is not stark, as opposed to look at hepatobiliary phase, the contrast between the lesion and the background parenchyma is very, very obvious. So it becomes easier to detect these lesions. Another way is that, again, remember that the early HCCs fall into this category of hepatobiliary phase hypointense nodules without aphy, so we can actually detect them. So notice here we have a case where clearly we have a sizable nodule, which is hypointense on hepatobiliary phase, and an MRI with extracellular contrast done a few weeks before this. We can't even see this nodule because it's not yet developed arterial phase hyperenhancement and washout. Also, getaxetate offers us prognostic implications. Hypointensity on hepatobiliary phase is associated with more aggressive tumors, whereas tumors which do have getaxetate uptake are associated with better prognostic molecular markers and are associated with improved survival after resection. As a matter of fact, compared to HCCs with getaxetate uptake, presence of hypointensity on hepatobiliary phase means 3 times higher odds of recurrence after resection or transplantation. There's also advantages for selection for definitive treatment of early HCCs. If we compare CT versus CT with getaxetate, and these patients are going for resection and ablation, there's improved recurrence-free survival, and some studies showed improved overall survival if we utilize getaxetate MRI. Why? Again, these hepatobiliary phase hyperintense nodules without aphy, it's a mark of increased HCC risk elsewhere in the liver. It's a mark of increased risk of HCC recurrence, and has a shorter time to recurrence, and then associated with increased risk of overall mortality. However, a few studies showed that if you treat these nodules at the time of resection or ablation, you actually improve recurrence-free survival. Another important feature is this peritumoral hepatobiliary phase hyperintensity. You can see these two lesions that you see a kind of halo around one and no halo around the other. So this halo is actually strongly associated with microvascular invasion, and it is independent prediction of post-resection and post-transplantation recurrence. There's also a little bit of improved specificity of HCC. You can see these two patients, very similar appearance of these small lesions with arterial phase hyperenhancement. The lesion on top, it has associated hepatobiliary phase hypointensity, and the lesion on the bottom is completely isointense. The lesion on top is LR4, confirmed to be HCC on explant, and the lesion on the bottom is LR2, probable vascular shunt, and we've been following it stable for 3 years, causing no issues. There are also some emergent uses for gadoxetate. We can use it for abbreviated MRI for screening, and there's also functional liver imaging score, which can predict decompensation and mortality. There are some pitfalls. Some of these are technical. Most important is quality of arterial phase. Transient severe motion is defined as severe motion-related artifact when patient is unable to hold their breath. It's sudden on onset, and it's limited to arterial phase. This is not something that happens only with gadaxatate. However, it is much more common with gadaxatate as compared to extracellular contrast agents. There's also a higher risk of arterial phase mistiming because gadaxatate, it comes with a lower volume, meaning narrower imaging window for acquisition, and we cannot use bolus timing to prevent liver parenchymal enhancement. There are also some interpretive pitfalls, particularly when we talk about hemangiomas. You can see here patient the same hemangioma imaged with gadaxatate versus extracellular contrast agent. Again, first 2 minutes appearance is very similar. By the time we get to transitional phase, we end up having what's called a pseudo washout because the background parenchyma begins to uptake gadaxatate, and you can see by 20 minutes the hemangioma looks really, really hypointense. The key to correct diagnosis is to recognize that the enhancement is going to be the same as intravascular pull on all phases. We see this peripheral nodule discontinue enhancement regardless of the contrast agent we're going to use. Where the issue may come in is we look at flash filling hemangiomas. You can see here's flash filling hemangioma versus small HCC with extracellular contrast agent is fairly easy to tell them apart. By 5 minutes, hemangioma retains contrast, small HCC washes out. The same two cases with gadaxatate, you can see that it becomes very difficult because of pseudo washout and hepatobiliary phase. It actually becomes impossible to tell them apart. So if you suspect hemangioma ahead of time, you should not use gadaxatate. If you do see hemangioma because you got gadaxatate for other reasons, remember, look for typical enhancement pattern and make sure that enhancing components are similar to blood on all phases. And if you suspect there's flash filling hemangioma, we may need to repeat contrast with extracellular contrast agent to make sure we're looking at that and not HCC or hypervascular mat. We also have to be aware of adequacy of hepatobiliary phase. We want to see enhancement of background parenchyma greater than intravascular vessels. And when that's not happened, we have to be aware that this is suboptimal hepatobiliary phase, which will affect how we interpret things. So for example, here we have a large lesion with arterial phase hyperenhancement and washout, but notice, right, so if we just focus on that, that's our definite HC LR5, but notice that on hepatobiliary phase, it's completely iso-enhancing to the background parenchyma, so we may be thinking, okay, maybe we should downgrade it to LR4 because hepatobiliary phase isointensity. However, notice that hepatobiliary phase is suboptimal, and therefore in this setting, we cannot use hepatobiliary phase isointensity as ancillary feature of benignity. Similar, we have a small lesion, and based on initial images, we would think that this is a hemangioma, but on 20-minute hepatobiliary phase, notice that it does uptake some contrast, so we may be thinking that this is a hepatocyte-containing lesion. However, if we recognize that the hepatobiliary phase iso or hyperintensity is not equivalent to uptake of gadaxatate when hepatobiliary phase is suboptimal, that will help us avoid this pitfall. Finally, there are some pitfalls which are operational. The exam is longer than usual because between the administration of contrast to hepatobiliary phase, we have to wait at least 20 minutes. They're also, depending on what we acquire before, up to 7 minutes additional. So we are looking at least about 30 minutes scanner time. Gadaxatate is higher cost than some of other agents. However, there are multiple studies listed here that show that gadaxatate may be most cost-effective strategy for multiple use cases, as you can see here. Finally, a few minutes to talk about protocol setup tips and tricks. The most important thing is that the protocol is dedicated and optimized for use of gadaxatate. So you don't just take your routine protocol for extracellular contrast agent and just put a different contrast in injector. It's very important to acquire MRCP before gadaxatate administration because we want to avoid T2 shortening, and we want to acquire T2 and DWI after gadaxatate injection to reduce injection time. This is just to show what happens if we acquire MRCP after gadaxatate. You can see T2 shortening and complete non-visualization of biliary tree. Importantly, how can we improve arterial phase? First of all, we do not use test bolus. We have to use bolus tracking. That would be the best. And to optimize AP quality, either use multiple AP acquisition or low a power injector rate with one-to-one dilution with saline. Example of multiple AP acquisitions, you can see that we can choose to focus on the one that has least motion and optimal timing. If you don't have multiple acquisition for arterial phase, this is a great option when we dilute getaxetate 1-to-1 with saline and slow down power injection to 1 milliliter per second. A large study that looked at this approach showed that 97% had optimal AP timing, with only 2% of cases having significant or severe uh, TSM artifact. This is just an example. Patient without dilution, you can see severe TSM on arterial phase. A follow-up study with dilution, perfect arterial phase timing and no motion. Can we predict suboptimal hepatobiliary phase? Well, there's a study that showed that if you use direct bilirubin cutoff of 1.3 milligram per deciliter, you actually can be very specific and you can predict it. And so if you are protocoling and you have just put your direct bili automatically into protocol sheet, if you see that there is a direct bili that's less than 1.3, or there's no recent direct bili, we can proceed with gadoxetate. And if direct bili is 1.3 or greater, we can switch automatically to ECA. So, few take-home points. Remember that hepatobiliary agents offer advantages for liver detection and characterization for both healthy livers and cirrhosis. There are technical, interpretive, and operational pitfalls. If you create dedicated and optimized protocol for gadoxetate MRI, that will help to minimize some of these pitfalls. I'd like to thank you for joining us today. I'd like to thank the Medscape for inviting me and for providing me the opportunity to share this with me.